The website is called Clinical Problem Solving. Sorry, let me put this up here. Boop, boop, boop. Okay, so yeah, Clinical Problem Solving, really cool website. They have essentially schemas like this for anything you would want as far as diagnoses go. And it's a great way to just kind of get like a broad sense of like, okay, what things should I be thinking about? So I wanted to go through this with you guys, and this will probably be kind of the framework that I use for a lot of these videos because I think it's very concise. So let's kind of dive into it. So what this is saying here, which we kind of talked about already, is first rule out your emergent causes. So usually these people, not always, but most of the time, are going to be hemodynamically unstable. And so this 4+2+2 rule applies to these systems where these people are in imminent danger. So the 4 applies to the cardiac system. So the things listed here are ACS, aortic dissection, tamponade, Takotsubo, cardiomyopathy. And then under pulmonary, you got PE, pneumothorax, and then esophageal is one of those other ones that we want to consider. So rupture, impaction just being like food stuck in somebody's esophagus could potentially, you know, shut off someone's airway, for example. So I wanted to go through each one of these first and just briefly be like, here's the first test or thing on the exam that you're going to want to know, or the thing that your preceptor is going to ask you, and then what the initial treatment is, just kind of briefly, and then we'll be done. That's it. So for cardiac causes, ACS. So remember, ACS is three different things, right? It's a spectrum of disease that gets progressively worse as you go down the spectrum. So stable angina is its own category. Stable angina is essentially somebody who has chest pain with exertion, and the chest pain is stable because it's not getting worse, it's not progressing, it's lasts for whatever the criteria is, like 10 minutes or less, and when somebody stops, exerting themselves. You won't see any EKG changes with stable angina, and you won't have any troponin elevations with stable angina. Now, and when you get into ACS category, this is when like interventions are going to start being needed in order to, stop somebody from potentially killing off some of their heart muscles. So unstable angina is progressive chest pain at rest that doesn't resolve with rest and is more frequent or whatever. There's like lots of different categories, but essentially somebody who has chest pain at rest that doesn't resolve with rest and is not going to have any EKG changes and not have any troponin bumps, but they have chest pain. So the important part about this is like this person doesn't have any necrosis of their myocardium because the troponin is not elevated. But this is potentially something that you could intervene on because the plaque that's causing the unstable angina can always dislodge and then cause a full blockage. So remember that ACS, one of the most common causes is atherosclerosis of the coronaries, right? And if a plaque gets disrupted and it breaks off, it can cause a total occlusion of the coronary artery, and now you have like a full STEMI. So unstable angina is potentially just a large brick of atherosclerosis that's now narrowing the coronaries to the point where even at rest, the heart is not getting perfused correctly, but is getting perfused enough to not die, essentially, if that makes sense. So the next step from there, and it goes from unstable to an NSTEMI. So an NSTEMI, again, the EKG is not going to show anything, right? But you will now have elevations in your troponin levels. So this is kind of like the idea of like the epicardial vessels are starting to not get enough perfusion, and so you have some like not total transmural necrosis, but you have some level of myocardial death. And this is something that obviously you're going to intervene on. And then the next step from there is STEMI, which is what everybody thinks about. That's your troponin elevations, that's your ST elevations on your EKG, and there's lots of other criteria, obviously, that you can look for depending on what phase of evolution this STEMI is in. If somebody is having an active STEMI that started 10 minutes ago, the EKG is going to look a lot different than, an EKG that is from somebody who's been having chest pain for the past 2 hours. So you can look up those criteria in your step two book and stuff like that to really like get a good firm understanding of that. But the things that preceptors are going to ask you about are what are the differences between all of these ACSs, like the spectrum of disease, how does it progress, and what is the cause and stuff like that. And then we'll talk about treatment. So if you have somebody you suspect has ACS, remember the acronym MONA BASH, I think is probably the most common that you'll hear. Um, so Mona Bash, so M is morphine. You want to control the patient's pain. O is oxygen. So if somebody has a low O2 saturation, you want to try to maximize the amount of oxygen that you're delivering to the tissue that's already not being perfused correctly. If you can have a lot of oxygen loaded onto those red blood cells as they're going by, even if the concentration isn't quite as much, you want to have a higher concentration difference between the tissue and the blood in order to really maximize, what blood flow is getting there. So that's important. Nitrites. So these come in all different forms. Most common is like sublingual is what they'll give it like most people on the ambulance when they're traveling. And they usually give that to people like for symptomatic, stable angina and stuff like that, just to help them feel comfortable when they have pain. But this is just to help control the pain. It will cause vasodilation, and potentially you can get some more blood flow to the area that's not being perfused correctly. Next two things, so this is a little out of order, but you want to think about dual antiplatelet therapy. So remember aspirin and like clopidogrel or some other type of antiplatelet therapy. Um, Different actions, but both are going to be important. And again, you want to use antiplatelet therapy because it's going to, like I just talked about with the plaque, going to help prevent clotting and help prevent that plaque from being an issue going forward. That's kind of the idea in a very basic sense. You want to make sure that they're on dual antiplatelet therapy to avoid any further progression along the ACS pathway. And then everybody that's having ACS, you want to give them a beta blocker. Obviously, you think about that classic like demand and perfusion problem, right? So if somebody's got a really high heart rate or somebody, like for AFib, for example, if somebody's heart is bouncing really fast, um, the overall exertion and demand of the myocardium is going to be much higher. So same kind of idea applies to ACS. You want to try to lower the heart rate to an acceptable range to help decrease the amount of necrosis that's going to happen based off of demand, if that makes sense. Um, and then statin, again, that's just another one of those like basic, we don't want this plaque to get worse type interventions. Obviously statin decreases cholesterol, which is a large portion of atherosclerosis and things like that. So that's important. And then heparin, usually, these people will be on like a heparin drip until they go in for their PCI, percutaneous coronary intervention to obviously decrease clotting. That plaque, if it gets disrupted, can cause thrombosis. That thrombosis can occlude the vessels, like we talked about earlier. So that's monobash. Morphine, oxygen, nitrites, aspirin, beta blocker, another antiplatelet like clopidogrel, statin, heparin, ACS, done. So the diag for the test, if this is what you're using these videos for, best test EKG, monobash is the intervention. I would say if you're given the option, beta blocker is probably the most important of those to give in order to decrease necrosis in the kind of the short term, just purely off of demand. Okay, that's a long one. Next one, aortic dissection. So aortic dissection obviously is dangerous because you essentially have blood that's just causing further dilation of the aorta, and the blood's not really going anywhere. So you end up getting like very poor perfusion to kind of distal organs, extremities, etc. Um, so some things you can look out for aortic dissection would be like, a widening of the mediastinum on chest X-ray is kind of your classic one. You'll have like chest pain that radiates to the back. You might have somebody that comes in who's super hypertensive, so that's kind of like the main intervention, right? Is you want to control their hypertension. The idea obviously is like with hypertension, the higher your blood pressure is, the more pressure you have pushing on that large artery, and that can eventually cause, micro tears in the wall until eventually it kind of separates the layers of the artery, and blood can then pool inside of that separation, and that's kind of the dissection, right? And if you have blood that's just pooling and it's not going to where it needs to go, you get poor perfusion. So you look for like, are the kidneys upset? Like, is their creatinine bumped? It can affect all kinds of arteries, obviously, distal stuff. So, yeah, you want to look out for that. So, like I said, I think, the main thing with aortic dissection as far as diagnostic tests go, I think for the test, what you should say if the patient is stable is a CT angio. Now, if the patient's unstable, I would do like a transthoracic echo, and that would be kind of more specific. Chest X-ray is not specific at all for aortic dissection. It can give you some clues. If you see it, great, but you're not going to see widening of the mediastinum every time you have a dissection. So CT angio if they're stable, TTE if they're not. And then treatment, blood pressure control, because the hypertension is the problem. And if you control the hypertension, it's not going to worsen the dissection. And then ultimately, the definitive treatment, yeah, that's aortic dissection. These next two, so is a whole animal on its own. We won't go too much into this because as a medical student, you're not going to be dealing with a whole lot of tamponade. You might see it, you might get asked some questions about it, so have like a kind of a basic understanding of what it is. Essentially, you have blood pooling inside of the pericardium that causes poor filling, which then causes poor ejection, which then causes death. That's kind of the synopsis. And diagnosis-wise, you can do it clinically, but to kind of prove it, ultrasound is probably the most efficient way to look at this and kind of get an idea if there's fluid around the heart. And then kind of definitive treatment would be to um, drain the sac, so do a pericardiocentesis or a pericardial window. Top key is subocardiomyopathy. This is going to be diagnostic. Look for stuff on the echo. You see kind of like that ballooning picture. This is more of like cardiology is going to manage this. But I think just knowing like, okay, I got to get an echo is probably, as far as clinically wise, enough for you to, get good grades from your preceptors, and knowing that, what to look for in the echo, which is like the ballooning of the atria. Okay, move on to pulmonary. So PE. PE is fairly common. I've seen a couple of them, a couple that are like massive, a couple that are like subsegmental and less symptomatic. They come in all kind of shapes and sizes. The most common thing that you learn as a medical student, I think, is really like a DVT gets dislodged and then that gets stuck in the lung and that causes the problems, right? Um, so, that's probably the most common thing. And so you'll see like when somebody is doing like a pulmonary embolism workup, they'll get, ultrasounds of the lower extremities to kind of look for that. Most specific for pulmonary embolism itself is going to be CT angio, similar to aortic dissection. It gives you kind of an idea of, if there's a large chunk of poor perfusion within the lung, you'll have a patient that has really bad shortness of breath, pleuritic chest pain in the sense that every time they inhale it hurts. And yeah, sometimes, I mean, if like somebody has like a saddle embolism where it's like both pulmonary arteries are completely obstructed, you might not even see that patient. They might be in the morgue. But if they have like subsegmental PEs, like really small ones, sometimes they might not even be symptomatic. But for whatever reason, maybe somebody had a low suspicion for them having pulmonary embolism, and they ended up being a D-dimer and it was elevated, and then you have to get a CT angio. You see it, you treat it. Anticoagulation for this is the first step and the definitive treatment. And there's like lengths of time that you should know, and definitely understand like the differences between the different types of anticoagulation. But that's a whole different beast that we can cover in another video. Okay, next is pneumothorax. So pneumothorax, clot lung tissue can happen for a variety of reasons: trauma, being tall and athletic, um, etc. Anyway, chest X-ray, not bad. Ultrasound, better. Um, treatment, depending on, I mean, there's lots of different types of pneumothorax. I'll probably make a different video on that. If it's just a simple pneumothorax, sometimes and it's small, they can heal on their own. They don't have to do anything. If it's tension pneumothorax, you stick a needle in, the intercostal space, let the air drain out, and then send them on their way to get further evaluated. Hemothorax, there's all kinds of different types of things associated with this, but simple pneumothorax, don't like to treat it. If it's a massive one like a tension, like I just said, you can usually diagnose that with a chest X-ray, and you'll see like the mediastinum is getting shifted to the opposite side from the collapsed lung, and that's where you want to stick the needle in and drain the air so that it has room to re-expand, and that way your mediastinum is getting crushed. That's why this is under the emergent causes. Esophageal, so rupture is like Borhave syndrome is like what you'll learn in medical school, I think. To rule this out, they would do like a gastrographin swallow test. And the reason they use gastrographin instead of like barium now is because it has less irritation of the mediastinum if there was any extravasation. But if you do a gastrographin swallow test and it isn't definitive, but you're still kind of suspicious, you might end up getting a barium because it is a little bit more specific, but you might get some mediastinal irritation from that. So just kind of keep that in mind. And then treatment is surgical for that, obviously. And then I don't really have a lot to say about impassion. I don't know if you'll see a whole lot of that, to be honest. Usually, like, I think about impassion, and I might be wrong, like I said, or you're a medical student, but I think about impassion is like somebody swallowed something that they didn't chew completely, and it got stuck in their esophagus, and their epiglottis is closed, and so they can't breathe. So if you see this in the hospital, they're probably either close to dying, or they got the piece of food or whatever it was out, and they just want to make sure they're okay. So hopefully they're not in like immediate danger in that sense. Okay, so those are the emergent causes. Everything else here we're gonna go through pretty quickly, but those are the higher yield ones that you want to make sure somebody has chest pain. We gotta make sure that this is not happening, right? So here we go. So schema, we follow this. It's negative. We go to now the next thing, which is also not emergent causes, and they classify it as anatomical, which I think is fair. So we'll start on the left side here. So MSK, so we'll go system by system. So costochondritis. Costochondritis is essentially like you think classically somebody's been coughing a whole lot from, whether they have an irritate like a COPD exacerbation or pneumonia or an asthma attack or whatever it might be, and they've been coughing a lot and it irritates kind of the musculature and stuff around the intercostals. And this is the person that's going to have the reproducible chest pain. You give them NSAIDs, good to go. That's about it. Rib fracture can be a similar mechanism to what I just discussed, or trauma. And there's not really much you can do for rib fractures, to be honest. I mean, if they're pushing on something else and causing, nerve pain or something like that, they might be surgical intervention. But otherwise, this is just symptomatic control, rest, physical therapy. Skin, like I talked about earlier, herpes zoster, you want to look at the skin every time somebody comes to the hospital. Depending on how early you're catching this, if somebody actually comes in, oh, yeah, I have chest pain, but it's this rash that I've had for the past, 40 hours, you can give them like valcyclovir as a treatment. Encourage people to get their shingle shots. That's about it. Thoracic radiculopathy, sure, that can cause chest pain, absolutely. There's lots of different causes of that. I'm not going to go into a whole lot of depth on that one, to be honest. Visceral causes, so going into GI, you can have like esophageal spasm, GERD, ulcers. All of these can cause what people might perceive as chest pain, especially the burning sensation can sometimes be very uncomfortable and persistent, so people confuse it for heart attacks frequently. Especially, you want to be careful with like females and diabetics and things like that, because if somebody's having like ACS, they might have totally different symptoms than like the typical, crushing chest pain, substernal, radiates down my arm into my jaw. That's like your typical ACS. But, there's females, diabetics that I've seen who are just like, oh, my stomach is a little uncomfortable, and you think it's GI cause, but you still got to rule out ACS. So just keep that in mind. Keep that in the back of your head. But for these things, so like esophageal spasm, you can get like nitrites and stuff like that. That might relax the spasm. You can diagnose this with like a swallow study as well. If you really are, going home about it, if they ask you a question about it, that's how I would do it. Reflux, give them some PPIs, proton pump inhibitors. Usually they use like protonics in the hospital, and you can give them like Pepsid as needed. And if it resolves with that, great. There you go. There's your answer. There's not really a whole lot you would do as far as like diagnostics. If they've had reflux for like 30 years and they've never been treated, then you might want to refer them to GI for like an EGD to make sure they don't have like Barrett's esophagus or something like that. Ulcers. Think about somebody who's a lot of like NSAIDs. Like the classic is like somebody who has rheumatoid arthritis and they've been taking aspirin or they've been taking ibuprofen by the handfuls for years, and now they have this chest pain and it ends up being an ulcer. These are diagnosed typically with an EGD. With ulcers, they're not always bleeding, but if they are, you'd see like a drop in somebody's blood count and stuff like that from the bleeding. So we usually track that if we're suspicious of an ulcer in the hospital to make sure that they're not like actively like squirting blood into their GI tract. But they would usually come in with like complaints of melanic stools because it's an upper GI bleed. So they might have other symptoms and stuff like that. But you also treat this with PPI in the short term. You transfuse if they're bleeding and their hemoglobin is less than 7, etc. Other cardiac causes that are not necessarily emergently, worrisome. Heart failure. And I'll probably do a whole other video on heart failure because there's a lot to it. But the one thing I do want to mention about heart failure as far as things clinically that you want to know is goal-directed medical therapy. So GD&T. So these are things that have been proven in studies to reduce mortality in people that have heart failure. And it's broken into heart failure with preserved ejection fraction, heart failure with reduced ejection fraction. So the things that work for heart failure with reduced ejection fraction as far as mortality goes, ACE and ARB, ARNIs, which are kind of new. Those are like your combo drugs that we that can decrease mortality. Spironolactone, beta blockers, and then SGLT2 inhibitors. Those are the 5 that when you're looking at a patient that has heart failure and they come in and they're being treated for like a heart failure exacerbation, you want to make sure that you're discharging them as much goal-directed medical therapy as they can tolerate. Obviously, like if they're naive to these drugs, you want to throw all of them at once. You'll have cardiology kind of manage that outpatient or even the primary care physician outpatient. But you want to get them on something to kind of start that trend of like getting them on a optimized regimen to decrease their exacerbations. So a common question you'll get from a preceptor is, what are the drugs that are part of goal-directed medical therapy and what are the mechanisms of action? So we're going to go through that before we start internal medicine. And then they might try to trick you and ask you like, why don't we just send these patients out on diuretics? That's what we're treating with them, in the hospital. Well, diuretics don't increase or decrease mortality. Diuretics treat the symptoms. Makes people more comfortable. It can kind of get the heart back to working at a normal, scheduled rhythm and rate and things like that, and make it squeeze correctly against less fluid, and makes patients feel better, but it doesn't improve mortality. So the things that are not goal-directed medical therapy are digoxin, diuretics, and nitrites. Those are all just kind of symptomatic management. So that's something to keep in mind. And kind of like we talked about earlier, demand ischemia, which is essentially where the heart is just like it's struggling. That's the heart failure portion, and you might have elevation components from that. That can kind of muddy the waters of ACS a little bit. So sometimes these patients end up getting like a stress test. If you're like thinking that it's a type 2 STEMI, which is what demand ischemia is. So just keep that in mind. Have that on your differential when you're talking about these patients. Aortic stenosis can cause chest pain if it's severe. Again, for kind of a similar reason to what I just talked about heart failure. As far as management goes, diagnosis first. Echo. Obviously, you want to do that. That's going to be your kind of definitive. Like, yes, you have aortic stenosis or not. Very common as you age. You get calcifications, it narrows, it happens. If it's like mild, moderate, you just want to make sure you control all the other conditions that could potentially worsen it. Underlying heart failure. Whatever, hyperlipidemia, stuff like that. You want to make sure they're optimized as far as their other comorbid conditions go. If it's severe, then you can do like a TAVR or something like that, where they like replace the valve. But I mean, if you're working in internal medicine like I have been, you're not going to be doing that. You'll be referring that obviously to cardiology. So yeah, that's that. Pulmonary pneumonia. I'm going to do a whole thing on pneumonia because there's so much to it, and I think talking about the antibiotics and stuff like that is important. Just briefly, pneumonia can also cause like pleuritic chest pain. Chest X-ray is okay. CT is better. Empiric treatment for like CAP is going to be azithromycin and ceftriaxone. Those are kind of like the brief points I want to talk about here. We'll have a whole discussion later because this video is already wildly long. I don't want to talk about that. Diaphragmatic hernia, meh. And yeah, fat necrosis, sure. So okay, that was a long video. Like I said, it was going to be, and I'm sorry. But I hope it was helpful. I hope that it gives you just like some things to think about as you are approaching patients with chest pain. It's important to have a framework to work within as you're approaching chest pain patients because you got to rule out scary stuff, and then you got to figure out if it's not scary stuff, how do I get to the other stuff and how do I treat it. So I'm hoping that some of the stuff that we discussed here is useful for you to kind of understand and walk through. And one of those videos that you can maybe watch like right before you start your internal medicine rotation. So if I missed anything or anybody wants to comment down below and give other people advice on things that they've seen in the hospital as far as chest pain goes or things that they think about, I'd love that. I want to keep the discussion open. And yeah, I'll see you guys in the next video. Thanks for listening. Goodbye.